Thank you very much, Dr. Yakov, for the invitation. Just one very brief comment about the United States. When this device was discussed in the United States, the answer was, well, we can pretty much open up the vessels. So the only conflict of interest I have is that I'm a proctor for Impella, but we're going to talk about all devices here. I think when we're in the cath lab and we deal with cheap cases, we have to kind of like pull from our hats all the magic tricks we have, whether that indicates techniques of opening up the vessels or support our patient to go through these cases. So a cheap case consists of 3 different circles where it's not only the anatomy of the coronary arteries, which is technically challenging, but also comorbidities that the patient has, including chronic kidney disease, diabetes, diffuse vascular disease, plus how good or bad our ventricle is and what reserve we have so that the patient can deal with the brief ischemia we induce when we try to open up his arteries. And this is just a brief slide from United States market, where actually out of all the patients who needed to really have atherectomy done so that we get a good PCI result, only about 5 to 7% got atherectomy. And part of that is because the operators were concerned of inducing longer time of ischemia and whether that could impact the outcome of the patient. So I'll briefly touch on 4 devices, the most common use. So intra-aortic balloon pump, all of us know how it works. Augmenting the diastolic pressure and technically increasing the coronary flow during diastole, but there is that IABP shock trial where it kind of like put it a little bit on the side as far as patients with cardiogenic shock are discussed. And when we think about hemodynamic support on cheap case, it's not for the time that our patient is stable. So the time where we need the hemodynamic support actually is the time where our patient is in brief cardiogenic shock. So that is where we need it, and this is why this slide applies to this. The main reason is balloon pump helps as much as it can help only when the pump works, so when the heart works. The more dysfunctional the ventricle, the less functional the balloon pump is. This is the reason why on at least the European guidelines, it got a class 3 indication for routine use in cardiogenic shock cases, but that doesn't mean that it cannot be used. So this is a brief case. It's a 51-year-old male who has known ischemic cardiomyopathy. He's an EF of 20%. He has an ICD in place. He had a PCI into his LAD for an anterior STEMI, and then presents a couple of years later with a shock from his ICD while he was resting. So he was cathed. We can see a right dominant RCA, not much there, but then as we see on the left picture, there is a subtotal occlusion on the proximal LAD. There is ostial circumflex lesion, and if we see closer on a different look, it's actually a very narrow left main bifurcation Medina 111 lesion. So this patient is resting peacefully on the cath lab table. He's not in shock, but what we decided to do was to put a balloon pump in and then try to see what we can do. I just remind he's a young gentleman, and he was evaluated at the time for heart transplant. There were no transplants, no heart for him. So we decided to proceed with revascularizing. Due to the anterior STEMI in the past, the anterior wall of the left ventricle was not fully viable from mid to the apex. So with the balloon pump in, we decided to cross both lesions, both to the left anterior descending and the circumflex, and then perform balloon angioplasty with DCB on the LAD, and then stent from the left main into the circumflex, as that was the most viable part of the left ventricle. So opening up the LAD, and then on the right screen you see this is the DCB balloon from the left main to the LAD, and then stenting left main to the circumflex, opening up the stent struts to the LAD, finishing up with pod. And this is the final result. And just to kind of like believe a little bit on DCBs, even on higher diameter vessels, the second-year follow-up of this patient is that he's tolerating maximum heart failure medical therapy, and actually he's not on the transplant list anymore since his EF has recovered up to 35 to 40%. So balloon pump can function in cases like that. Then I'll touch briefly on Impella and IVAC. So IVAC is a device which is somewhere sitting between balloon pump and Impella. So it actually works with the same mechanism of the balloon pump. It receives blood from the left ventricle and then pulls it and pushes it back in the aorta over the aortic valve. As far as the Impella goes, it is an axial flow pump. It's non-pulsatile. And what it does, it suctions blood from the left ventricle, pushes it up in the aorta, and comes in three different output modes, like the CP, which gives up to 4 liters of cardiac output, the 5.0 and 5.5, which is more surgically placed and for longer term, kind of like bridge to transplant therapies. And there is also the Impella for the right ventricle, not available in Greece at the time, the Impella RP. So what it does, when the heart functions okay, the output of the device is lower, and as the ventricle gets dysfunctional when we do a high-risk PCI and we either rota or balloon the left main, and our patient goes for a very brief time in cardiogenic shock, that's where it pulls up and gives a better support. So the plan is, anytime we have either a cardiogenic shock or a high-risk case that our patient starts having dysfunctional left ventricle, so we're close to curve number 4, we try to pull him closer to the left and down and improve the output. And as far as cardiogenic shock goes, it's the first 24 hours. It's when the patient comes in that we either save him or not, because that's where the main mortality is. And as the days go by, the patients get stable and improve. So this is a case of a 72-year-old male who had prior PCI from the left main to the mid LAD for an anterior STEMI. Now he comes with a distal RCA lesion as well. He has an EF of 20%, and he has a lot of other comorbidities, including cirrhosis, he had a stroke, and he has severe COPD. So the EF is 20%, and the whole anterior and left side free wall were viable with a cardiac MRI. So he was turned down by CT surgery, and then when we decided to cath him and take a look, you can see a protruding stent from the left main into the aorta. Then it's occluded all the way up to the bifurcation. And then as far as the RCA, you can see it's a big dominant right, where the PLV branch actually supplies with collaterals all the left coronary system. And here's a very simple and straightforward lesion on the PLV branch, but this is what keeps him alive. So when we decided to proceed, our plan was to obviously attack the left main as well. What we decided to do is put an Impella in, fix the RCA fast and quick, and then move on CTO of the left main. The challenge was all that stent hanging out in the aorta, so we went sidewalls closer as close as we could into the ostium of the left main, the true ostium, get sideways into that stent, and through that actually move on and do a CTO PCI. I don't want to delay you into this. There's further discussion there. What you can see on the left side screen is actually all the stent hanging out in the aorta, which is still formed like oval shaped as when it was deployed. Then we decided to proceed stenting into the mid LAD. And then since there is like that dominant circumflex, small circumflex, but I had an ostial lesion there, we decided to just DK crush it and open up both vessels and finish up with an ostial balloon to crush what was the residual stent hanging in the aorta on the side, so it doesn't come into the way later in the future if that is needed. And this was the final result. And finally, about ECMO. ECMO is a device used most of the time for cardiac arrest patients. So we need to keep our patient alive. It's not a device that respects the heart muscle, and especially when we use it, we have to pair it with a device that helps the left ventricle to function. All of us know how the VA ECMO works, but on a heart that is in need, this is actually the picture. So when the ECMO works, and this is a picture where you actually see a heart with a diminished LV function on the left panel, where actually the contrast stays into the ascending aorta and is not pushed away by the heart, because it's all pulled back from the cannula, from the arterial cannula. And on the right side, you see a normal ejection fraction, how it is fighting with the cannula on the ECMO side to get the contrast further down. So anytime we try to put ECMO on a patient who's in cardiogenic shock, or we think might go into cardiogenic shock, we should keep in mind that if we're talking about a dilated left ventricle, then about 80% of those patients will come out with either a surgical VAD or a heart transplant. They will not come out with their own heart. If the left ventricle is not dilated, then about 80% will maintain their heart and recover, and only 20% might require a surgical VAD or a heart transplant. So yeah, we shouldn't rely on this. We don't want to see that picture. So anyone, please, who uses ECMO should always keep in mind, I have to do something for the ventricle, unless it's a very short period of time that the ECMO is going to be needed. All of these devices have complications, most of them vascular, but this applies to all the devices we talked so far. So we keep in mind large bore access comes with a pay at the end. And since we've all been used how to put our vests when we're on the plane, the most common and the most known incident was at the Hudson River, where the plane landed on the river, and only 2 of the people on the plane actually ended up putting their vests on to survive. Thank you very much for your attention.
Thank you very much, Dr. Taleb, for this excellent presentation. Any comment from the discussions? Dr. Dallas.
Excellent talk, Adam. Actually, the problem, I do believe that Impella is number 1. The problem, as you well know, especially here in Greece, is the price and the logistics. And in our hospital, I'm going to present a case later on, because of this, we have implanted but very, very few Impellas. And we have a program with ECMO, but in very high-risk PCIs, we put the ECMO, and then by finishing the case, if it's a very risky case, we stop the ECMO and we implant an intra-aortic balloon pump, or we do it together. But if the Impella was cheaper or more easy to go through, of course, Impella would be the number 1. Well, congratulations, very good talk.
Thank you.
Thank you.
Yes, Dr. Gabrielatos.
Congratulations. Just a short question. There are no short questions. I think the answer may be short. Do you think, Adam, that you can use it as a bailout, the Impella, or because the cases that you showed us with Impella, it was a program case. It was not in a cardiogenic shock. Do you have, how much time do you need? 5 minutes, 10 minutes? And here in Onasio, can someone tell us how much time do you need to put the VA ECMO?
So Impella insertion is actually really fast, because the only thing you need is a good stick into your common femoral. And unless obviously there is a severe aortic stenosis or a metallic aortic valve or some kind of like contraindication, then it doesn't take a lot of time to get it in, especially if it's a healthy aortic valve on a relatively young guy who comes in with an LAD STEMI and in shock. That shouldn't take more than 5 to 6 minutes to get the device in. And the other good thing is that you can still move on and do even your PCI with single access through the main sheath, so you don't even need an extra time for extra sticks. and more risk of an adverse event. Impella hasn't shown on registries that is as good if you put it at need. So if you start the high-risk PCI and it doesn't go well and you rush to put it in, it's not as good as it is if you do it ahead of time. And that partly because you might lose your time. If you don't have the stick ready and the patient is already with an ACT of like 250 or 300, you might run more risks with a bad stick, bleeding, and all these kind of like side effects that you have when you rush to do things. Ideally, you use it from the very beginning. Otherwise, you can still plan and have it as a backup plan, but with not as good results as you would get from the beginning.
Dr. Taleb, I wonder, which is the Greek reality? You use very often these devices or not? What's your opinion?
I'm pretty sure not as often as it should be used. Actually, I think only a very, very small percentage gets this device. There should be very strict indications on how it is used. So not on people with like a cardiac arrest, unknown downtime, like all these things that could alter and give you a bad outcome because you might recover the heart, but not the brain or not the liver or not the kidneys. But generally speaking, there are ways of establishing good criteria and use it. And it's not that much difficult device to use.
Okay, thank you very much.
In this aspect, just to add an encouraging prospect, we are trying in the several committees to get approval and from the central authorities the use of Impella. At least at this point, our proposition was at least for cardiogenic shock and for high-risk PCI, stick to use with specific criteria. This was by our proposal with Dr. Pereas as well and the other intervention cardiologists who are trying. After that, hopefully, after a year or so, I think the picture in Greece, which is disappointing up to this point, will improve.
Just on the, so we had some experience in the UK from being part of the BSIS CHIP study. So this was a randomized study of people going in and having Impella versus no Impella, a bit like Protect 4. And what you learn from it is two things. One is that if you have the Impella, you'll do more. And the second that you learn is that sometimes where you're absolutely certain that you are going to need an Impella, if you're randomized to the non-Impella arm, if you're really effective and you have good procedural planning, you do less, but you may do less better and more efficiently. So there's going to be a place for this. What we've also realized is that if you're going to be a danger shock type center, you will never be successful unless you're doing the procedures regularly, and the only way you can do it regularly is in planned cases. So there's that conflict that you sort of have to balance, because you can't put this in the middle of the night and not mess up legs if you're not doing it day in, day out in other settings.
Thank you very much.
Okay, it's my pleasure to present the next speaker, who is